Lumbar fusion surgery. What is a fusion? A fusion basically means getting two bones to fuse together, to literally grow together. So how does that happen? Well, the motion occurs across the disc and the facet joints. As those get arthritis and degeneration and problems and herniations, they can start to collapse down, cause pain, and pinch nerves. Well, a fusion basically allows us to open everything back up and stabilize it where it never moves again, so it doesn't hurt anymore and it relieves the pressure on the nerves. It's a great surgery and it really has fundamentally helped a lot of people. But there's also a downside. One, it's a bigger surgery to put in screws and rods and to lock things in place. There's risks with that. The other problem is if you stop the motion of one level, it can put more stress on the levels above and below. And that's why sometimes people need other fusions down the road after the original surgery. So we obviously try and avoid that any chance we can. So there's different ways to do the fusion. There's probably 1,000 different techniques to do the fusion. The traditional one that was done in the past was to fuse people in the back. Open up the back, open up the muscles, put in screws and rods, drill out the joints, put in bone, take bone from the pelvis and lay it down across the joints and across the transverse processes in the back, hoping that bone would grow together and it would fuse. Well, there's problems with that old school technique. A couple of them. One is all this muscle dissection in the back causes a lot of back pain. Another problem is if people have slips and deformity, when the discs degenerate, everything collapses down. That's why we get more and more bent forward as we get older and we lose height. Well, what you don't want to do is to fuse somebody in that bent forward, collapsed, flat back position. Because if this disc is collapsed down and we lock it in place in that position, the other discs have to hypercompensate to get to stand up straight, and the whole weight of the torso weighs more because it's out from the axis of rotation. So the second problem with old school fusions is fusing people in deformed positions. If you get them stuck in that position, it puts more stress on the other levels. And then the last one is basically, are you able to open up the room for the nerves and do it as minimally invasive as possible? So the fusions that we do these days, typically we take out the disc and fuse the disc space for a couple reasons. One is it corrects that alignment where it gets the height back and the lordosis back, so that if you're going to stop the motion, at least put people in as good a position as you can. Another thing is 80% of the weight goes through the disc space. So bone growth needs compression. It needs to be under weight. And so 80% goes through here. So if we take out the disc and put the spacer and bone into the disc space, it increases the chance of getting a successful fusion because that's where all the weight is occurring. As compared to the old school fusions all in the back, only 20% of the weight goes through the posterior elements, so it has a higher chance of a non-union and a failed fusion. The bone never actually grew in 20 to 40% of people. So that's another reason why we do these techniques where we either go from the front, the side, or the back to take out the disc and put in spacers. What do we call that type of fusion? Is an interbody fusion. This is a vertebra, which are vertebral bodies. In between the bodies is the disc. So if you take out the disc and fuse, the disc is called an interbody fusion because it's in between the bodies. So how do we do that? There's three basic techniques. One is to go from the front, one is to go from the side, and one is to do it from the back. The front is called an A-lift. The A-lift allows us to cut the front of the disc and open it up, get the height back. Then we put a spacer in, either metal, plastic, or bone that's wedge-shaped. This is the spacer that opens up the front. The downside of doing the A-lift is you got to move blood vessels out of the way, and you can get hernias and different issues, especially in larger people. Another type of approach is to go from the side, called a lateral or X-lift or D-lift, where we go from the side and take the disc out from the side and put the spacer in from the side. And here's a type of space we put in from the side. Both of those spacers from the front and the side are very big and really open everything up and get a high fusion rate. The side has the benefit of not having to retract the blood vessels and can be done in larger patients because everything falls in the front. The other way we do it is from the back, called a T-lift or transforaminal interbody fusion, or PLIF, same thing, basically. Typically what we'll do is we'll take out a facet joint and get to the disc in between the nerves, take out the disc and put in the spacer from the back. The downside of that surgery is there's a smaller hole to work in, so the spacers that go in are about 1/3 of the size of the ones from the front and from the side. But that surgery is good for obese people or older people, or for some reason we need to address direct pathology back there. So there's a lot of different ways to do fusions. The other component is you need some type of fixation. You got to stop the motion to get the bone to grow. It's like if you break your arm, you put a cast on it, which stops the motion so that the body can make bone. Same thing in the spine. You got to stop the motion. So how do we do that? The most traditional way is to put screws and rods, pedicle screws and rods in the back. You can either open up all the muscle in the midline to put the screws in, but the downside of that is it can decrease some of the blood supply and the function to the joints above and below. The way we typically do them now, we do it percutaneously, which means we come in at about a 30-degree angle through 2 small incisions, bluntly go through the muscle, put the screws in with this computer navigated system that we use, that we've used for 15 years. It's amazing. We've put in thousands of screws like that. There's still a risk of putting the screws in, but it makes it extremely safer and faster and less invasive. I don't have to expose everything. I can put this in with this computer navigation and save a lot of the muscle and blood supply to the levels above and below. So that's percutaneous, put these screws in, and then the rods, and they lock together. That stops the motion and allows the bone to grow. The pedicle screws are stronger than anything else. I've also used clamps, one-sided screws, plates on the side. There's all sorts of different less metal, but the screws work the best on both sides. They provide the most stability. Another option is there's devices that have screws that go through the device, but those screws just aren't as big, so they don't provide as much stability as the screws in the back. So those are mainly the different techniques of how to do the fusion. The results overall, it really depends on how bad somebody is. This is a generalized result discussion. Most people's pain averages around an 8 out of 10 before a fusion, and typically averages around a 3 out of 10 after the fusion. So if you're in an 8 and you're in agony and you've tried everything else, a fusion can really help you. It can help you stand and walk and get back to your life. But a 3 out of 10 after surgery means some people are a 1, some people are a 5. A lot of people still have some pain and discomfort, and just expect that. You may be better, but not perfect. As far as complications go, there's a lot of different complications with spine surgery and with fusions. You really should speak with your surgeon about what are the complications with your particular case. Suffice to say that don't take the surgery lightly, but if you're really suffering in pain, it can definitely help you. So your options at this point are: 1, you can contact us directly at info@watkinsspine.com. You can also call for an appointment, 310-448-7890. Or you can watch one of the 3 videos on the different types of fusions. The A-lift from the front, that's most applicable if it's the L5S1 disc, because that's the bottom one. We can't go from the side because your pelvis blocks L5S1. So L5S1, a lot of times we go from the front. If you have a big slip and a big deformity, going in from the front, we've shown gets the best correction. If your problem is at L4-5, L3-4, L2-3, typically we'll go from the side. We'll do the lateral X-lift, D-lift approach. You can watch that video. And if you want to watch the other video, we also go from the back with the T-lift. That's the least one that we do, just because it doesn't get as good a correction and the spacers aren't as big as from the front and from the side. Thank you.